Okay, everybody, this is Jean Culp. Some of you, she's given us a presentation before. She did one on aromatherapy. Remember that a few months ago? She is a nurse practitioner for the hospice inpatient unit. And she's going to talk to us today about bathing and skincare.
Hello, everybody. Hi. I want this to be really informal, so if you have questions along the way, feel free to raise your hands, or you have experiences you want to talk about, just let me know. Today we're going to talk about really, when you're bathing our patients, you're really having an opportunity to really look at their skin. And so you all, as either in home health or in hospice care, you really play a very vital role in communicating and helping us to know when patients who are having skin issues, you're probably the first person that they see them or identify them. So today, even though it says bathing, we'll talk about some of the products you can use in bathing, but also we're going to touch a lot on wound care. And I'm going to show you some pictures of what different types of wounds look like, because I want you, it's not that you assess, but in your role, but you, as I said, may be the first person to see them. So I would like you to feel a little bit more self-confident in what you're seeing and what you think that you're recognizing. So when you talk to your case manager or care manager, notifying that nurse or physician or nurse practitioner, that you feel a little bit more self-assured of what you're seeing and reporting. So thinking about what are important skills for you all to possess as you're giving skin care and bathing the patient is, number one, protecting the skin. Something I'll point out later is our skin is the largest organ that we have. So it's very important that you protect it. Ensure that if the patient has open areas, that they remain covered. There are some dressings that are water absorbent, but the important thing is for you to recognize that, and then to make sure that if an open area does come, or let's say the dressing does come off, that you notify somebody about that, because I know and I found that you all are not capable, or not that you're not capable, because I know if you were at home, you'd probably be just dressing it yourself. But there, in your role, you are to notify the nurse when that happens. Maintaining moisture balance. That's also very important. If our skin gets too dry, then there's more risk for it to break down, because it's going to become very brittle, dry, cracked. Next thing you know, you've got skin openings, skin tears. The other thing is helping patients stay clean and comfortable and provide the skin care to reduce the risk of breakdown. So those are all very key roles that you all play in helping to keep the patient as healthy as possible. You perform a number of important roles, keeping the body healthy and free of infection by creating a protective outer layer over the inside of the body. These are functions of what normal skin does. And then also, it helps keep the moisture in and keep the body cool during the summer heat by allowing the sweat to come out from the glands of the body. So if our skin is functioning normally, it either sweats if we get too hot, or if we get too cool, it constricts and helps, trying to keep that heat in. So it's real important that we keep the skin nice and moist, and so it stays intact, so it protects our body. So with that said, thermoregulation is very important as far as a primary function of the skin. It's a very important function of our skin. Like I said, it vasodilates to help improve our circulation, or it constricts and we sweat and we release that sweat if our body gets too hot. One thing for you all to consider when you're bathing someone, you do find an open area, and maybe it was dressed before the dressing comes off, it's real important for you to notify that nurse right away, because what happens when a wound bed gets exposed? It cools down. A wound bed needs to be kept warm. It really needs to be at around a temperature of 96 degrees, or 98, 96, 98 degrees, for it to be optimal for healing to occur. Many of you all know you're caring for patients who they're not in optimal health. Their nutrition is poor, they have other disease processes going on, so they already have lots of things working against them for that wound to even have a chance of healing. But the longer that wound bed stays open and cool, the less chance they're going to have. And it actually, by the time that it does get dressed, a dressing gets put on, it can take up to 4 hours for that wound bed to get back to a good temperature for healing to even potentially to occur. So this is why I try really hard to make dressing changes less frequent. You know, it used to be said that we need to change a dressing every single day. Well, we don't. Because every time you pull that dressing off, again, you've cooled the wound bed down. So chances for it to heal, you know, you just reduced it. Not saying it won't, but you've reduced the chances. So better off, the longer you can leave something intact, the better. So if you should find something, the sooner that you can notify the nurse so that they can get there and address it and get that taken care of, the better. So there's a lot of urgency to that. When problems occur with our skin, well, there's lots of things that can happen. I mean, they can get a simple infection within it. They can get into even more severe problem. The patient can become septic. Again, I pointed out earlier, the skin's the largest organ we have. I think you might see that somewhere in writing when you're doing your little testing. So you might want to remember that. And in hospice and in home care both, like I said, our patients are nutritionally depleted. They have multiple comorbidities. So with all that said, then they get into what we call skin failure. And I'll show you in a little bit some photos, and we'll talk about some of the things that can really happen, especially in our hospice world. And I'm sure, Tarika, you've seen some of that happen. The most common problem with skin is skin tears. And I bet every one of us here have seen skin tears from time to time. These can be as simple as a small cut or a scrape, or it can be a major wound with exposed vital parts of the anatomy. So these patients that you all are caring for, most likely their skin is very fragile. So when you're bathing them and caring for them, it's really important not to rub too hard, because you can actually tear their skin by doing that. So it's real important to be careful when you're doing that, so handle them with care. Another common problem is many of them have a problem with moisture. They're dehydrated, they're not taking lots of fluids, and so, or even with our aging process. Even with normal aging, our skin can lose elasticity, and so it's really important to keep that skin as moist as possible. Here's that word on this. So normal skin maintains a healthy amount of moisture, but what we don't want is it to be like slathering, and you don't want it to be too moist. I gotta say, Papa Bear, Mama Bear, Baby Bear, Papa Bear, this is too dry. Mama Bear, this is too moist. But Baby Bear, oh, this is just right. Well, that just right is homeostasis. You want a balance. So when I teach wound care to nursing, one thing I tell them is, your dressing change, what you use, that therapy may have to change from time to time, because you may start out with a very moist wound, and all you're doing is putting a dressing over it to cover and protect, because you don't want to add more to it. It's already too moist. You're trying to wick some of that drainage up and dry it up a little bit. But with that said, some of the times, then it can become too dry. So then we have to change and add maybe some hydrogel to it to help moisten it up. So it's a balance. And it's a constant balancing act that we play. So, like I already pointed this out earlier, some of your patients you may find are dealing with cracked or dry skin. They're very dehydrated. Those can cause lesions and become very uncomfortable for the patient. Damaged skin can also lead to problems with blood circulation in some patients. So it's real important that we're considering that, that when we're working with our patients and when you're doing their bathing or doing your light touch massage, again, being gentle with handling the skin, but also with that massage that you're all providing, you're also helping to improve that circulation. So, again, balance. Dealing with skin problems in the home care patient requires a variety of measures. Again, should you identify a new wound, what's the first thing you do?
When you identify a new wound, you go tell someone.
That's right. You need to let somebody know. Who is that somebody?
You're the nurse.
The nurse. And let's say you don't see the nurse, or you haven't talked to the nurse and you see me in
Then
the
I call
hallway.
my supervisor.
You can call the supervisor, you can let me know. I'm very involved in the home care with hospice patients as well.
Oh,
So,
okay.
but I would prefer you go through the case manager or the supervisor, but let's say you've had problems with that and you see me and it's late hours and I'm the only one here, go ahead and let me know, because I can get a hold of somebody to get some treatment going,
Okay.
okay? And I'll show you in a little bit a communication tool that I use with the nurses too, that I find to be pretty effective. We also have to be careful that, like I said earlier, friction, that can cause problems, or shearing, scooting them on the
Turn
pads,
sheet.
the turn sheet. Yes, you have to be extremely careful because, like I said, that skin is very, very fragile. The head of the bed, we like to try to keep it up at about 30 degrees when possible. Some patients can't tolerate that. Some patients say, no, I want to lay flat. Some patients are like, no, I need to have my head up higher. The important thing is that they're being moved around.
Right.
That's the key takeaway. The knee gauge while the head of bed is elevated, you have to be careful with that too, because you can get pressure back here when you do that. Because when you're using one area of the bed and you're raising it, guess what's happening to the knee gauge? It starts coming up. So you gotta be careful and watch that. Some patients can use a trapeze bar to help be a little bit more mobile and help them to scooch around a little bit. Sheepskin heel or elbow protectors are really nice. I know we have some of those foam padded devices in the supply closet. I've seen the waffle boots, anything like that to help keep but the biggest or best thing you can do and the cheapest way to protect those heels, if you're worried about you have dry, cracked heels or they're boggy. Do you know what I'm talking about when I say boggy? You touch them and it's like
Soft, mushy.
yeah, real mushy. So what you want to do then is what we call offloading. And you can literally just take and double a pillow and just put it so that the heels are offloaded from the mattress. Because if you leave them buried down in that mattress, pressure starts happening, it doesn't take long, those can be open. So, other in high-risk areas, some use of transparent dressings, skin sealants. Unfortunately, right before I came down here, I was dealing with a patient. I was just telling Vera she has vulvar cancer, and she has what we call a fungating wound of the vulva, and it's nasty and it's oozing, and so got to protect that skin all around it, because guess what, if we don't, then that's all going to break down. So there's things we can do. Moisture barrier, I can't tell you enough how important this is for you to use, especially on their bottoms or in their peri area. Either this or the Cavalon spray works really well. There's also another product that we have, and I didn't find it in the supply room right now, because I don't think we're stocking it, but it's available. It's called Marathon, and it's like blue. It comes out looking blue, but it's like a liquid paste, and it'll cover the skin. So let's say if you're worried of being incontinent and you're worried about drainage getting in those areas,
Right.
when you're bathing and you clean them up,
Right.
slather this on, or
Okay.
use this, just whatever barrier you have available. If you don't have it, talk to the nurse, because we need to make sure we order it and get it there. That's one of the best things, because if they do urinate, or they do leak fluids, or they have stool, it'll get on this first. So your skin can be protected, or their skin. So do that, always consider that. And then of course moisturizing the skin, very important. I used to do this in about, also making sure if they do get up to a wheelchair, if you're in homes and they do sit up, I have seen breakdown from where they rub against the sides of the wheelchairs. Or the other thing, let's say they're trying to scooch themselves up. They're using their arms, guess what? I've seen skin just literally torn away from the undersides of the arms from them doing that. So you know, we need to think of, do we need things like jerry sleeves? Have you all seen jerry sleeves or seen those used? They're just a sleeve material, and then there's padding, like a foam padding that's in them, so it helps protect. Therapeutic massage. Definitely want you all to consider the use of the therapeutic massage when you're out with these patients. I can't tell you enough how much your visits mean to them. Number one, I mean, there's socialization that occurs when you get out there. It's time to sit and listen to them. You're a visitor for them, and they love it. I hear that time and time again. Oh, when I say, how's services going? Oh, I love my home health aide. I can't tell you enough how great they are. They give me such wonderful baths. I'm going to send you each home with one of these today, but we have supplies, we call them the grab and go supply with aromatherapy. And this is lavender that is mixed with an unscented carrier lotion, just coconut oil. And you can use this. I sat this morning with a patient before she left to go to the nursing home, and she was anxious. So I sat with her and I did massage. Well, by doing that massage, I helped comfort her, but I also helped improve some circulation. I also helped myself because I'd had a very busy morning and I'm like, I need 5. And it literally just takes like 5 minutes to sit with them and do this. And it means so much. So places you can use this on, I mean the arms definitely and the legs, but consider the coccyx, the heels, sacral area, the hips. That's where the ischial tuberosities are. Sorry about that. It must be 4 o'clock. Think about the pressure on the back of the skull. If they're just laying like this, earlobes. You know, we've got a patient up there, she's on the hospice unit right now, and she lays so much that the earlobe is literally folded over. So I had to unfold it and rub and circulate that to help. Again, the elbows. These are all areas that therapeutic massage can come into play and be very important. When you position them, think about, you know, how you're positioning them and the use of the pillows and where the pressure is. Try to put them in a 30-degree lateral position from one side to the other. Use of pillows or wedges to separate the bony prominences. And this slide here is just a review of where all those bony prominences exist. There's more, but I didn't put the ones for face down, the nose, the chin, all that, the head. But these are the major ones to consider and think about. So the turning, repositioning, when you're doing the bath care and really thinking about where should I give them more massage and take the greatest care is remember these areas because they're the first if they are really embedded into something that they're going to break down. So, and remember I talked earlier about offloading the heel? I mean, you can use these boots, but this is really the cheapest and the easiest way to do it. And we do that all the time up on the unit. And sometimes they'll wiggle and get out of it, but it's real easy just to double it back up and fix them up there. This is just a picture to show how dry and cracked this foot was. And then this was it afterwards, an after picture, just after using some moisturizer. Let me just share a little secret on what I do when I'm in the nursing homes with patients and I'm doing that massage. A lot of times at night, what I tell them to do is I lather those legs up with that moisturizer and then I put socks on. And then that really helps it to get in there and you won't believe the difference that you have. So it makes a world of difference. So, but you can see this dry, cracked skin.
And look on that toe.
Right there, yeah, you've got like a little callus area. Yep. The moisture itself, just using the moisturizer itself and massage and all that, it's going to help to take that off.
When I do massage them and lotion them, I don't rub it. I don't have it laying on the skin, but I don't rub it all the way in because I like for it to kind of soak in. Is that good?
That's fine.
Okay.
Maybe massage a little bit and
Yeah,
put
I'll
some
massage
more
it.
on and just leave it.
Yeah.
Yeah. But the massaging is going to help improve the circulation.
Yeah.
In many cases, Patients with cracked or dry skin will require application of moisturizers to help. You saw that with the last slide. It's especially important when you're dealing with diabetic home care patients, as they often lose an amount of circulation in their feet. Some of them can't even feel it. They may have an open wound. I've seen that time and time again.
So bad.
Right, right. So, you know, so it's very important, otherwise we can have severe damage to that part of the body and it be way advanced before they ever see it or find it.
Right, and that's not good for, especially for diabetic.
No. No, it is not. So, possible signs of, or common signs of possible skin damage: obvious cracked skin, skin tears, redness or warmth of particular parts to the body in comparison to another. So sometimes you get what I say is like kind of like a dermatitis that can occur. Usually if they have a dermatitis, both sides have that little bit of redness to them. They match.
Right.
Yeah, you don't usually get cellulitis bilaterally. If it's a cellulitis, it's usually one side. So there's a difference. So the right leg has some more redness. You have a concern. Again, I'm not asking you all to diagnose that or assess. I'm just wanting you to have that awareness so that when you see it exposed, either way you're going to report it. But just so you kind of know, it's very rare for patients to get bilateral lower extremity cellulitis. I've seen it, but it's very rare. It's usually one side. But, or you all of a sudden you come to see them and you see they have a new rash. That's important for you to notify the nurse right away. Hospice wound protocols. Now, I know some of you are home care, and I apologize for this, but yet I think it will also help you because it's not that I'm trying to educate you to use the protocols, more so that you get familiarized with some of the things that you're probably already seeing out there. So it's probably going to be like, yeah, aha, when you see some of these pictures that we talk about, but you know kind of what our philosophy of care is and how we treat wounds, because it is a little different. We're not quite as aggressive. In home care, I'd be more aggressive than what we are in hospice. It's great if we're able to heal a wound, but that's not our number one goal. And yet, even in home care, I'm sure your number one goal is keeping the patient comfortable at the same time while you're trying to heal. So ours in hospice says to provide relief of pain, reduce the number of dressing changes when possible, which I'm sure you would like that too in home care. And also reduction of odor. I'm sure that applies to home care. Reduce risk of infection, and when possible, heal those wounds. So types of wounds we see, I was amazed when I came here at the types of wounds. And I will tell you that our person that we use, our company that we use to supply our wound care products is Medline. And that rep is available to me at a phone call or an email, 24 hours a day, 7 days a week. I've emailed her or called and she has gotten right back with me. But every time she hears Jean Culp's calling, she said, oh my God. Because she said, and I work with other places, but you guys have some really challenging and difficult wounds.
Like burns, right? Would that be the same thing?
We don't see a whole lot of burns. We see things more like, pressure wounds, Kennedy ulcers, fungating wounds. Those are my, I will never forget. One of my first home care visits that I went out on was a woman that had breast cancer. And this was a dear friend of Dr. Giesel's, and she had asked me if I would go out and just see this patient. And I went out there and I was almost in tears. There were t-shirts, like men's t-shirts, hanging around on the backs of chairs, hanging on, in the bathroom, with dried, crusty drainage all over them. And a spray bottle. And what they were doing was, they would put this t-shirt on her in order to get it off because the fungating tumor was draining. They were spraying her down. She would stand there like this, and she would cry while they were spraying her down and removing it. I was in tears. I'm like, oh my God, this is beyond me. I left there because at that time, I was new here. I didn't have wound care certification. I had some experience, probably enough to just be dangerous. But it was at that point I'm like, I need to go for some training because this is, and one of the first thing they teach you as you're going through nurse practitioner training is you don't have to be smart and know it all, but you need to know who your resources are. And I was fortunate enough that I knew and had reached out to Terry Warner, who manages our outpatient, St. Vincent Outpatient Wound Care Center. I called her up and I said, I will buy you lunch. I don't care. You can go at dinner. We'll stop for dinner. I don't care, but I need you to go with me because I need some help.
Yeah.
And she did. She went with me and we looked at this dressing, her wound, and she made some good suggestions. And so I grew upon that knowledge. So, yeah, we get some horrible wounds. I just dealt with one on the unit. I was telling you about the volvular cancer. It's fungating. And I'll show you a picture of a fungating wound here in a few minutes. It looks almost like cauliflower-like. And they drain. And they can be so nasty. And they're so painful for the patient. So we see lots of them. We see those fungating wounds I talked about, gangrenous or necrotizing wounds. How many homes have you walked into and went,
Mm-hmm.
So I know you've seen them. Again, remember your aromatherapy. You know, I am the aromatherapy queen, so remember your aromatherapy with us because that's helpful for not only you, but for the family and for the patient. Fistulas, we've seen those, skin tears, surgical wounds. Oh, we've had some nasty surgical wounds. You know, when they've opened the patient up, they found a mass, and they're like, we're just gonna have to close that up, but then in the process, it starts eviscerating or coming apart. We've had patients on our unit that has happened, and we do our best to try to help make it the most pleasant experience we can for the patient and for the family, because those are nasty. Venous and arterial wounds, neuropathic, diabetic wounds, and Kennedy terminal ulcers, which we'll talk more about here in a minute. Some wound care terminology you may hear us nurses talking about, and you probably see it, so I wanted you all to have it, is thinking about eschar. That's that black, leathery, could be brown, leathery substance that you see. You see them maybe on heels. You see them on the sacrum in the wounds. It can be anywhere, but it's often dark, black or brown and leathery in appearance. Exudate is just the drainage. Full thickness wound, that's when you have wounds that extend deep into the dermis of our subcutaneous tissue. Partial thickness wounds, those are just superficial loss of tissue of the epidermis. The epidermis are early into the dermis. Peri wound, I used to think something else when I heard that. I was like, what is a peri wound? But it's the skin that surrounds, the intact skin that surrounds the wound. Slough, that's that stringy looking white, sometimes it's yellow, gray or brown, stringy tissue that can be inside wound beds. Tunneling, you all heard that. Probably felt or seen those. Yep, those are not pretty. And undermining, that can happen too. And that's just the loss of tissue around the wound margins. So again, skin is the largest organ of the body. Remember that? 3,000 square inches, receives a third of the body's blood volume. Every minute of the day, we're losing 30 to 40,000 dead skin cells off of the surface of our skin, which is about 600,000 particles of skin every hour, equaling about 1.5 pounds per year. That's probably about what I'm lucky to lose even when I diet. By age 70, the average person will have lost 105 pounds of skin. So like I said, as we age, our skin gets thinner. So that's why it's so important that as you're bathing them, you're keeping the skin as warm and covered as you can. You're protecting it, moisturizing it. Those things are so, so important. We class wounds here. We use a very popular classification system. We stage them. And I'll go through some of these and tell you a little bit about them. But at stage 1, basically, you know, you see a reddened area on the skin. There's no breakdown. It's just red. And so For it to be a stage 1, what we do as nurses, we test it. We're looking for what we call blanching or circulation. So stage 1, there's no blanching. There is no circulation happening. So by that, that means that wound is really at risk very quickly to continue to deteriorate and open up and be in worse shape than what we start with very fast. So we really have to be careful with those areas and protect them. Stage 2 is just a shallow open area, also without drainage. Stage 3, you may see necrosis, you have a full thickness skin loss, you may have minimal to moderate drainage depending upon where it's at and the type, or you may see slough. Or you can have a stage 4, which we've seen lots of those, with full thickness tissue loss, and with those you can probably see, muscle, you may see bone, everything. I had one in the abdomen once, we were using a flashlight to look around up there. Nasty. So this is what a stage 1 pressure wound might look like that you might come across. Again, the best thing you can do in your role, A, is notify the nurse. But also, you can protect that area in the meantime until somebody's going to get out there. So make sure that whatever it is that's causing the pressure, alleviate it. So if it's because they've been holding their arm up against that wheelchair, get that arm off that wheelchair. Think about, do they have any pillows? Anything like that that you can do. Turning them onto the different side. So, if it's the heels, offload the heel. This is what that stage 2 pressure wound looks like. You see they're dry. There's no drainage to them, but the skin is open, right? This is a stage 3. You can see there's this slough. Yeah. So this is this would be the peri wound that we talk about. Sorry. Oh, that's just requested. I didn't wear my glasses, so this is why I'm like this. So that's your stage 2. Stage 4. This one gets a little nastier. Oops, I'm sorry. Stage 4. A little nastier. This may be bone, muscle. On here, they're very nasty. Yeah. This is another thing you may see. Deep tissue injuries, especially if you're just out in a home where somebody's just been transported home. They just had surgery. They maybe been in the hospital and they were transported home by EMS, and suddenly you find this little purple or maroon localized area of discolorization on them, and you can't figure out why or what. You don't know if it's, you don't know exactly what caused it, but you see it. Usually there's something more that's going on in there and brewing. They may have had pressure from the gurney. They may have been in surgery and been restrained in some manner or something, and it's caused pressure there, but you can rest assured that this will soon become something else. Yes, it will soon. Usually it will open up and show itself off on what it is underneath. So these can be very painful. They can be firm or mushy. Usually they can be warm or they might be cooler compared to like tissue here, if you're seeing it here, because not good circulation is getting through there. So you might feel coolness there. But usually those areas are purple or maroon in color. This is like what one looks like here. You can see the purplish color here. That's what that looks like. Again, I'm not asking you all to diagnose. I just wanted you to maybe feel a little bit more comfortable in what you're seeing, so you feel a little bit better when you're talking to your nurses, or and also it also helps because you're front line. So you're seeing them first. It might be hours before the nurse gets out there. So unstageable wounds. We talked about that slough earlier, that stringiness. If there's so much of that in the wound bed that I can't really see anything else, we call those unstageable, because you don't know what's under there. So until that comes off, we don't know. And sometimes we don't want to know. Even with that black necrosis, now I'm talking more on the hospice side than on the home care side. On the home care side, you all may be more aggressive and doing more palliative type things, and you may be more aggressive using things like you may have seen or heard Santal being used. That's an enzymatic debrider, and they put that on there, and they're trying to soften that all up, and trying to get that dead tissue off so they can get that opened up and heal from below. In hospice, we look at that as they have enough stuff going on that a lot of times we're just painting that with betadine and keeping it dry. We don't want to know what's under there, and we don't want to open it up and open them up to other opportunistic infections. So again, it varies. So you may see or hear of two different ways. If we're really working on trying to heal it and we think we can, then sure, we're going to learn to breathe and get that off there. If not, then we may be painting with betadine, leaving it alone, offloading, trying to keep the pressure off. Comfort being more the goal. And considering the patient. Everything is to be patient-centered in everything we do, so that's what we keep in mind. This is what an unstageable wound looks like. You see, I cannot see that wound bed. I don't know what is under it. It's that black leathery appearance, that eschar that's all here. Now, if I were working with the wound center, I can tell you they would take their scissors, and they would start cutting away and trying to get that black eschar off. They'd be using Santal and trying to get that all moisturized up so that it would come off, because they want to see what's under there. Otherwise, they can't get to the wound bed to heal it. Yeah. For us, in hospice, not so much. Now, have I done it in hospice? Yes. We had a patient who had something like that. It was such foul odor coming from that wound. You may remember, this has not been too awful long ago. And the wound center actually came over and helped me to debride it. And there was so much gangrene underneath it that we really felt like we needed to get the gangrene out. And then we started packing it with what we call Dakin's solution. Yeah, and that's an everyday dressing change. But we were packing it with Dakin's gauze and trying to help decrease the bacterial burden and trying to help heal it from the inside out. He eventually died, but at least we got it all cleaned up, and we medicated him very well before we did it, but it's not the norm, is it, Rick? No. Skin tears, I know you guys have all seen these many, many, many times. And again, you know, our policy is that you find these, protect them. I mean, use some common sense with protecting them, but you still have to notify the nurse so she can get the treatment going. We see a lot of venous stasis ulcers, and we see these usually on the lower extremities. They have very irregular wound edges. Very superficial wound. Usually they don't have pain to these. We find them like on the medial lower aspect of the leg, or the middle, or on the ankle, or on the outer aspect of the ankle in the malleolar area. And here's what they look like. I hope you can see that right here. It's got a real irregular border, ruddy in appearance. And then we see arterial ulcers, and I know you guys have probably seen a lot of these. Now with the venous ulcers, you probably see drainage. The reason is because with the venous ulcer, there's still circulation getting there. The arterial ulcer, not so much circulation getting to the leg, so drainage is really minimal. So those oftentimes look dry. You'll see these between the toes, or on the tips of the toes, or on the phalangeal heads, or around the lateral malleolus. We have to be careful that a lot of times they're suspected because of footwear that they wear too tight of shoes. A lot of times they'll have thin, shiny, dry skin there on these lower legs. because they don't have good circulation. Hair loss on the ankle and the foot, you see those real thick toenails. They may even have a decreased temperature, feel cool, might even look a little bluish when you elevate them. Not have really good pulses, maybe not at all. And that's what these look like. Have you seen those on the toes? I'm sure you guys have, because I know I've been in many homes with some of you, and I know I see many patients that have those. You see, this looks like a more punched out type of ulcer. Yeah. Neuropathic ulcers, these occur on the lower extremity, even wound margins, deep wound bed. They may have cellulitis. Some of them might even have osteomyelitis. Sometimes you'll see granular tissue present unless they have peripheral vascular disease. These patients have low to moderate drainage, and you might see them on the plantar aspects of the foot or on the toe. Look at the here, or on the heel. This is the fungating wound, and it is so painful. You can see it kind of has that cauliflower looking appearance. Have you all seen these? No? I'm happy that you've not seen them. But just in case you should, yeah, this is where the malignancy has extended, started here in the breast, and it's gotten through the subcutaneous tissue, and now it's extending out and it's growing, and it's very, very, very painful and has a very pungent odor. Kennedy terminal ulcers, I know that I briefly mentioned this a little bit ago. These occur, like we said earlier, skin is the largest organ you have. Let's say you were in patient's home today, or let's say 2 days ago, and you did a very thorough skin assessment when you did their bath and you didn't see a thing. Now today, you're in their home and you turn them over as you're doing your bath and you go, oh my gosh, what happened? And you suddenly see these, they can look almost like a butterfly or a pear shape. I have a patient right now in the inpatient unit. She has one that I swear is textbook. When I looked at it, it looked so much like the butterfly back there on her sacral area. Like, this is Kennedy. The skin is failing. So the skin is an organ. When you start thinking about system failure and your patients are becoming more and more towards the terminal state, the skin is going to fail at some point too. So these can have red, yellow, black, purple colors. They can progress in as little as 36 hours. Usually the first thing out of your mouth is, wow, these were not there. Or a family will say, oh my gosh, I don't know how this happened. I have been so diligent with turning, Mom. I have tried everything, and they'll feel terrible about it. So one thing you can help do is make them feel a little bit better about this is beyond anything you could have done. This is happening as a result of they having system failure. So it's really helpful. It helps, I think. Yesterday I felt like I was doing service recovery with a patient's family on the unit because they thought, when did this wound occur? It was not there 2 days ago, and now it's here. And the daughter was a nurse, and I educated her about that, and immediately the conversation went from anger to, oh wow, you're right. I mean, I never thought of that. Never even thought about that happening. So oftentimes, I thought I had a picture on here. I'm sorry, I do not. How bad of me. Well, I'm sorry, I thought I had one, but I don't. But,
I have a question.
sure.
Sometimes, I wish we had a picture of it.
I know, and I'm so
Because
sorry.
I saw, and then I thought I was taking care of someone, and like the next day when I came back, it was like right from the tailbone on half of both cheeks, and I said, wow. I said, I've been turning her, and I'm trying to explain to the family, this was not here yesterday when I was here.
Right.
You know, and they said, well, how did you get like? I said, we've been turning her. I don't know what happened, you know. I did mention, I couldn't think of the name of Kennedy.
Yep.
But But then, like the next day, it started fading,
Mhm.
like going away. Is that possible?
Not usually.
Oh, that must have been something else then.
Mhm.
Cause,
Not usually. They don't go away.
oh, it was still there, but it was not as prominent
Okay.
as it was like the next day or whatever. But I was
Or
just
maybe
like,
your eyes just adjusted to what you were seeing for the first time, because it is like an eye open. I mean, it's like, wow, what the heck happened here? I've been diligent, and I know the family's been doing this, and
we're creaming her
it will not matter what you do. If a system is going to fail, it's going to fail. And so that's really important to convey to the caregivers at home, because they feel like such a failure themselves. They feel like something went wrong. They tried so hard. And I always say, yes, you did. You did everything right. You did everything you could. It's just, this is another system, just like their kidneys are failing, or their liver, or their heart. This is another organ, and it's going to fail. And we see it so many times. Now, where this got started, this whole phenomenon got started, is there was a nurse, and she's actually from northern Indiana. I don't want to say the name of the town because I forget. But she's now nationally known. Her last name was Kennedy. She worked in hospice. She saw this time and time again, and she started saying, there's got to be something to that. So she started doing her own research and publications, and so now that's the reason, that's where it got its name, Kennedy. But it's just skin failure, and it's the organ failing. This is how I communicate with your RN case managers. I developed an S-bar. Do you guys do S-bars at all? No? Okay. All right. So I just wanted you to know that they, used to, they would stop me in the halls all the time and say, oh, I'm out seeing Miss So-and-so, and this is going on, and they want suggestions or advice, or a couple of times they wanted me to come out on site and look at them, which I will do if I need to give some, support or education or whatever, or make some recommendations if it's a complex wound. And on one occasion, one of the nurses stopped me and said, hey, can you go next Tuesday over to see this patient? And I swore they said Hooverwood. And I said, yeah, that'll work, because I have a doctor appointment anyway I have to go to down the road. I'll go there, I'll be there at 1, and when I get done, I'll come on over there. Well, I got done there, and I'm calling, and I'm like, where are you? I said, I'm on my way. I said, what room are you in? He's like, room? And I said, yeah, what room? So I know which room to come to. And he's like, well, I'm in Fisher's at home. And I'm like, oh, okay, so my bad. I didn't know. And then it happened with another nurse, same kind of thing. And I wasn't, she said, oh, can you meet me out at this home? Well, I had went with her before, but I go to a lot of places. And with my own dementia, yes, I'm Exelon Club. With my own dementia, sometimes I forget these things, and I'm not paying attention. I'm just along for the ride. I had rode with her out there, looked at this woman. Well, she went on out. Was it waiting on me, thinking I would remember my way? No, did not happen. So then I'm like, okay, we're going to go to this. And this has been working really, really well. I just have a template for them. I ask them, I've educated the nurses on this and said, save it to your desktops. And if you have a complicated wound that maybe you just need some suggestions, tell me. If you have something that you want me to come out and meet you, tell me that too, because I'll be happy to, but just let me know when and where. So this is how I kind of, triage, so to speak, my days by the number of these I get. Because let's say I'm rounding on the unit and I don't have that many patients to see and I'm done, then I can head out and I can go to wherever I'm needed and see patients with wounds. So I am available for that, but this was just an example that I shared with them on how to fill that out. They just give me the patient name, address or room number, type of wound they're dealing with, measurements, because the nurses will come out. If you find a new wound, they should be measuring them, figuring out what type it is, staging it, if that's appropriate, because only pressure wounds are staged. And then going along with, in hospice, our protocols And I'm not sure how, do they just call the physicians? Okay, so the nurses are checking with the physicians on treatment orders for those. But specify a reason they need me and any other significant information. So that's how I communicate. And from the bottom of my heart, I want to thank you all for all that you do, because you're VIPs out there, and I hear it time and time again how much they love you and the care that you provide. And so like reading on your little Facebook page when you were out there, I'm like, yes, that's exactly what you do. You all have a passion for what you do, and it shows. So thank you for what you do. So those are just some references. These are my 2 grandchildren. I have that show. They were on our Harley Davidson. It looks like they're like on our basketball court out on the back, but the wind was blowing it up. It looks like the wind is blowing in their hair, and they're riding. So that's my Addie and my Ethan.
Ethan looks like he's having a ball.
Oh, not so much. Addie, not so much. She's looking at him like, what the heck are you doing? Okay, so is there any questions or anything that you guys have?
Can you hold on just a second?
I'm going to pass out. These are, and again, these are available
All of
as
them